Thank you again to all of our residents. A reminder that the winner of today's competition will be featured in the October edition of the GOGS newsletter. Now, our final lecture for today, and please stick around for after the lecture because I believe there's one more large prize to give away. We are honored to have our final lecture brought to you by Dr. Abisogun. He is going to speak to us on a proactive strategy for reducing cardiac-related maternal deaths. He is an interventional cardiologist at Candler Hospital at South Coast Health. He graduated from the College of William and Mary in Williamsburg, Virginia, where he had a full academic scholarship. He then went to medical school at the Rutgers Robert Wood Johnson Medical School in New Jersey. He did his fellowship at Brown University, and then he did his residency at Brown University and did a fellowship at UNC Chapel Hill. So please welcome Dr. Abisogun. Thank you.
Hello, so thanks for having me. It's an honor to be here. Let me make sure I know how to use this. Click it. Okay, it's an honor to be here. I'm very honored to talk on this topic. Okay, so I have no relevant disclosures. So I have sort of broad objectives, it's sort of ambitious, but in a nutshell, we're going to focus on pregnancy-associated myocardial infarction, cardiomyopathies, and preeclampsias. So this has been brought up, but a cardiac patient, a pregnant cardiac patient, is a complex patient. And best management is team-oriented with multiple different specialties involved in the care of these patients. One thing based on some of these case presentations that's missing here is good imaging. Obviously, if you have, that was a wild case, but cardiothoracic surgery, interventional cardiology, nursing, neonatology, obviously obstetrics and gynecology, and maternal fetal medicine. All those specialties really need to work as a team to ensure the best outcomes. So as we all know, there are many alterations in the cardiovascular hemodynamics during pregnancy, like a 50% increase in the blood volume and the cardiac output, which can lead to worsening left-sided heart conditions when aortic valvular disease is in play. But also, there are hypercoagulability that also happens with increased risk of thrombus formation, which can lead to even cardiac embolic events in the coronary arteries. Hormonal shifts also happens. We'll touch on this as we go. So I like to start with a case. So we have a 33-year-old G2P2, is that right? G2P2 at 32 weeks gestation who presented to the emergency department. So this young woman, she had 1 hour of substernal chest pain, which radiated to her back with associated diaphoresis, sweating, nausea, and vomiting. On exam, she was pale. She was diaphoretic, clammy. Her blood pressure was a little soft at 90/50, and she was satting 95% on 10 liters of oxygen. Lung exam was unremarkable, and she didn't have any tenderness in her calves, et cetera. Her OB assessment was notable for a viable intrauterine pregnancy with normal fetal heart sounds. Her EKG is up there. This one, you can see in the lateral leads AVL, she has 2 millimeter ST elevations with some reciprocal depressions inferiorly in 2-3 and AVF. And then she got a repeat EKG. I guess her symptoms weren't taken too seriously, but the EKG definitely progressed, and you can see tombstones in V2, V3. Those are the septal leads with reciprocal ST depressions. And those are those. So she was diagnosed with an anterior myocardial infarction due to a thrombotic occlusion of her left anterior descending artery. She was treated with aspirin, Plavix, and IV heparin. She was taken to the cardiac catheterization lab where the occlusion was found. It was opened up with a bare metal stent. She was eventually sent to the CCU in the maternity ward, and she was discharged. A few weeks later, she had a term cesarean section at 39 weeks. So that's an example of pregnancy-associated myocardial infarction. The definitions of this condition can vary, but it typically occurs between 6 and 12 weeks postpartum. It can occur longer after delivery, but it also can occur, just like the case I just presented, during pregnancy. These conditions account for 20% of maternal cardiac deaths. So just a review of the pathophysiology of a STEMI. Now, in pregnant women who tend to obviously be younger, it is not as often a plaque rupture where you have an atherosclerotic lipid-lading plaque within the intima of your coronary artery, which ruptures, and then the lipid core is exposed to the bloodstream, and that causes a thrombotic occlusion of the artery. So on that right-hand column you see with the ST elevations, that is usually due to a 100% occlusion of the artery due to a thrombotic lesion. Now on the left, in the green, with a non-STEMI, you can have a partial occlusion of the vessel, but what we see in these cases is the vessel isn't completely occluded and you still have some flow. So the EKG does not show the ST elevations, but you still can have an elevation in your cardiac biomarkers. In young women, one thing we can often see is spontaneous coronary artery dissection, which can also lead to ST elevations the same way as a thrombotic occlusion can. But the pathophysiology is different. There's, as we've touched on, increased shear stress within the coronary arteries due to increased blood volume, increased cardiac output, and some hormonal changes which cause increased laxity of the vessel. During pregnancy, that can cause tearing or sharing of that intimal space, and that underneath that subintimal space, there can actually be thrombus formation within the false lumen and occlusion of the vessel. So SCAD, or spontaneous coronary artery dissection, can also cause STEMIs and non-STEMIs in the pregnant population. And the last, I didn't put a slide for this, but the last thing is just a simple embolization of a thrombus into your coronary artery, which can occlude the vessel as well. So the epidemiology, this is a study that looked at 55 million pregnancy-related hospitalizations. Essentially, there is about 8 cases per 100,000 of STEMI or non-STEMI. 20.6% occurred during the antepartum period, 23.7% during labor and delivery, and then 53% occurred postpartum. STEMIs, or those 100% occlusions of the vessels which lead to myocardial necrosis, as we touched on, were 42.4%, and a majority were actually the non-STEMIs at 57%. 53.1% of these patients went to the cath lab. That's only 53.1% of these patients. That's important. And a quarter of them received some sort of revascularization, whether it be stenting, like the case we presented, or cardiothoracic surgery with coronary artery bypass graft surgery. In-hospital mortality was significantly higher for pregnancy-associated myocardial infarction, and the incidence of this is increasing over time. The diagnosis is made with symptoms. It's very important to pay attention to symptoms. Women present with coronary artery disease differently than men. Obviously, we know about chest pain, crushing chest pain going to your neck or down your arm, radiating to your jaw. That often is the classic presentation, but women often have other associated symptoms like nausea, vomiting, sweating, fatigue, things that we don't see with men as often. So the index of suspicion has to be high. So once you figure that out, then you get to the electrocardiogram, which should help you make the diagnosis, and cardiac biomarkers are also important. High sensitivity troponin and not CKMB, which was used in the past, is recommended. So when is chest pain to worry about? It sort of depends. If patients have chest pain, which is pressure, vague, tightness, center of the chest or left-sided, if it radiates to the neck and jaw, those are more typical of chest pain associated with ischemia, cardiac ischemia. The chest pain that's on the right side at one point that doesn't radiate, no association with activity or shortness of breath, that is less likely to be cardiac chest pain. So it just sort of depends on the symptomatology. This is a chart of a lot of symptoms, but I think we went over most of them. And there's a broad differential diagnosis with pregnancy-associated myocardial infarction, including aortic dissection. This is sort of beyond the scope of this talk, but aortic dissection, pulmonary embolism, Takotsubo or stress-induced cardiomyopathy, peripartum cardiomyopathies, which we'll touch on later, myocarditis and preeclampsia are all within the differential diagnosis. Now, something to keep in mind is preeclampsia, even in women with normal hearts, you can have elevations in high sensitivity troponin in that setting. So with the management of STEMIs on the left and non-STEMIs on the right, with a ST elevation myocardial infarction, that's a class 1 indication to go to cardiac catheterization lab regardless of where in the pregnancy the patient is. Class 1 indication, it has to be done. Now, with non-STEMIs, it sort of depends. If the patient does not have ST elevations, but there are signs of electrical instability like VT, VF, SVT, or hemodynamic instability like hypotension, just sort of like the patient we presented up front. Those patients are considered high risk, and even in the absence of ST elevation should go to the cardiac catheterization lab. Patients that are stable without active symptoms, without new onset heart failure or other concerning findings can be managed more conservatively, but it should be in a sort of pregnancy heart team with multiple different specialties involved. So a concern that usually comes up is fetal exposure to radiation. And some women sometimes are excluded from the cardiac catheterization lab due to fear of radiation exposure. But the important thing to look at here is percutaneous coronary interventions. The milligrays for that type of procedure is less than 1. And really, to begin to get fetal abnormalities, you need 50 times that dose to really have a problem. So there's really no reason to delay if a patient needs to be taken to the lab. It's a busy slide, but really what to remember here is certain drugs are okay and certain drugs are not okay. In the heart patient and patient that's having a myocardial infarction, Plavix is preferred. More current data suggests ticagrelor or Brilinta for the myocardial infarction population, but in pregnancy it has not been studied, so we still recommend Plavix in that situation. Aspirin is okay, but after 32 weeks, it should be a baby aspirin, 81 milligrams, because of the premature closure of the ductus arteriosus. So even after 32 weeks, aspirin in the setting of a myocardial infarction is still recommended. It's just a dose-reduced aspirin, 81 milligrams. The typical treatment is 325 milligrams up front. Beta blockers are okay. Heparin is okay as well. Lytic therapy is really only indicated in patients that cannot get to the cardiac catheterization lab within 90 minutes. Hopefully, we can avoid that in most settings, but in some rural areas, you may need to give lytics. Nitrates can be used, but can lead to hypotension, especially in right-sided myocardial infarctions, which can lead to fetal hypoperfusion. So depending on the situation, those could be used. NOACs such as Eliquis, Xarelto, Rivaroxaban, Apixaban are not okay in pregnant patients. Statins, ACE inhibitors, ARBs, aldosterone antagonists, I'm sure we all know those. Those are not appropriate for the pregnant patients. So unfortunately, with myocardial infarctions, sometimes bad things happen. So cardiac arrest can happen, especially if the infarct-related artery is not open in time. So If that were to happen, if someone goes into ventricular fibrillation, cardiac arrest, et cetera, no medication substitutions or dose modifications are required in the code. If it's a code blue, if the patient needs to be resuscitated with pressors, et cetera, you use what you need to use. One recommendation, and I haven't had this situation, I'm curious if anyone has, but continuous manual uterine displacement to offload the aorta cavo compression during the cardiopulmonary resuscitation is recommended. That's really the only difference. And then IVs, often we put femoral central lines in during these code situations. Recommendation is the central access should be above the diaphragm for that same reason. And preparation to perform an emergency C-section if no return of spontaneous circulation is obtained within 4 minutes. One interesting point is this is recommended to occur where the code is happening. So there may not be time to sort of prep the OR and do what needs to be done in that situation. So with cardiogenic shock, that's another potential complication of myocardial infarction. Often we see this with left anterior descending or left main occlusions that are not opened in time. If the patient doesn't expire, the LV or left ventricular function is severely reduced, and that can lead to poor organ perfusion and end organ damage. So in this situation, mechanical circulatory support can act as a bridge to full recovery. There are many different options for this. We have intra-aortic balloon pumps. Those have sort of fallen out of favor because they don't actually increase the cardiac output, they decrease the afterload. This device pictured here is an Impella, which is basically a device, a pigtail catheter we can put in the left ventricle to increase the cardiac output and increase the filling pressure of the coronary arteries by decreasing the left ventricular and diastolic pressure. Another approach is extracorporeal circulatory devices such as ECMO. Those are also used in this situation. Importantly, there's not a ton of data in this realm for obvious reasons, so more research will need to be done. But ECMO as well as Impellas have been used in pregnant patients with cardiogenic shock, and we have Impella devices now that can be placed surgically and be left in for weeks. Important with this device is they have to be heparinized, but as we've gone over, heparin should be okay in this scenario. We did sort of touch on the WHO classification of maternal cardiac risk. One condition that significantly increases the risk of death is peripartum cardiomyopathy. It's idiopathic, and basically it's heart failure secondary to left ventricular dysfunction. It typically occurs towards the end of pregnancy in patients that have no prior history of heart disease. So those patients that have myocardial infarction due to a occluded left anterior descending artery and have heart failure as a result of that, they are not these patients, though some of the treatment algorithms are going to be similar. So there is a geographic variation in presentation. In the United States of America, we tend to see these patients present 1 to 3 months postpartum. In this study, the European cohort had more of an even distribution of presentation, and the South African cohort, a majority of those patients actually presented at the same 1 to 3 months, but there was a delayed presentation, 3 to 6 months, that was also apparent in a lot of those patients. The etiology of peripartum cardiomyopathy is likely due to secretion from the placenta of an proangiogenics like SFLT1, which inhibits VEGF and causes endothelial dysfunction. This is a similar pathophysiology to preeclampsia. The timing of the presentation of these biomarkers has an effect. Patients usually have a spike in SFLT1 and prolactin, and then the cardiac output and the left ventricular function decline soon after that. So in this trial, the take-home message here is the weaker the heart is, or the lower the left ventricular ejection fraction, the worse the outcome. This looked at patients with LVEF at 2, 6, and 12 months, and looked at events such as death, transplant, and left ventricular assist device placement. And what was basically found was the percentage of events was much higher in patients that had an ejection fraction less than 30%. So the weaker the left ventricular function, the more likely you're going to have a major adverse event. Importantly, there are disparities as well. In the African American population, there's a less likelihood of recovery of the left ventricular ejection fraction as well. So the treatment algorithm is usually based on the severity of the disease. So in stable patients, we want to make sure if the ejection fraction is down that they're on nitrates, beta blockers, diuretics. Bromocriptine can be considered after delivery. In the unstable patient, we sort of touched on some of the treatment options, and those would include mechanical circulatory support with implantable LVAD or ECMO. Again, complete recovery of the ejection fraction is very important in subsequent pregnancies. In patients that have an ejection fraction that is less than 30%, it's more likely that they will develop cardiomyopathy in subsequent pregnancies. And how we counsel our patients, it's pretty important. I actually use this chart with my patients. So if the ejection fraction is less than 50%, those patients are still at a high risk of relapse. The risk of death or heart failure is greater than 10% in these patients. And the risk of preterm delivery and the preterm death is also apparent. Now, in patients that have LVEF less than 50%, they are at a very, very high risk of recurrence. They're at a high risk of heart failure with subsequent pregnancies, and I tend to recommend for those patients not to get pregnant at all. And that's not a very large reduction in their ejection fraction. That's 50%. But patients that have an ejection fraction greater than 50%, though they're at a substantial risk in subsequent pregnancy, their risk of heart failure or death is less than 10%. So they can get pregnant, but they do have an elevated risk of heart failure with subsequent pregnancies. It's just usually they have a good fetal outcome. Oh, very important. Either of these cohorts, subsequent pregnancy is not really advised, so a good contraceptive plan is recommended. So going on, we have the hypertension states during pregnancy. Preeclampsia occurs after the 20th week of gestation, and proteinuria, impaired liver function can be present. So the important thing to remember about the preeclampsia is patients that have preeclampsia, small for gestational age, and preterm delivery, I meet these patients usually as they get older. As you add small for gestational age, preterm delivery, and preeclampsia, the likelihood that these patients will develop major adverse cardiac events, plaque rupture, myocardial infarction, increases significantly. Patients that don't have any of them, it basically just follows the natural history of cardiac disease post-menopause. But in patients that have these conditions, the risk of those conditions increases significantly. So risk factors for preeclampsia includes multi-fetal gestation, primiparity, obesity, elevated body mass index, and pregestational diabetes. We touched on this. With pregnancy, there should be an increase of about 50% in the blood volume as well as the cardiac output. Stroke volume increases by about 27%, and the heart rate can increase anywhere from 10 to 15% as the pregnancy progresses. So what should happen is, as the blood volume and cardiac output increases, pregnancy-associated hormones increase the nitric oxide and should allow for an increase in cardiac output without the development of hypertension. In preeclampsia, this is going to look familiar because it's the same thing as peripartum cardiomyopathy. The placenta increases SFLT1, which is an anti-angiogenic and which decreases VEGF and increases inflammation, endothelial dysfunction, and can actually lead to pulmonary edema, can lead to hypertension, can lead to, so endothelial dysfunction is at the core of atherosclerosis formation. So if the endothelium is sort of disrupted, those lipids can get into the coronaries and cause those lipid-laden plaques that lead to plaque rupture. And nitric oxide is also at the core of this. Nitric oxide is reduced, so the vasodilatory effects that are placental mediated are deranged. There are twofold increases of cardiovascular disease, hypertension, stroke, and CAD later in life. So management, so a room of OBGYN, so, deliver the fetus. If the patient has preeclampsia, that is at the core of management. Complications include HELLP syndrome, which can be fatal. I don't think I need to review HELLP syndrome. Shouldn't come from me anyway, right? The antihypertensives, that's something that I do a lot of. We want to treat when the blood pressures get high, greater than 160 over 110, certainly. So we want to identify patients that have preeclampsia. We want to look for lab tests for proteinuria, dependent edema. If there are complications such as HELLP syndrome or fetal distress, urgent delivery is required. Now, some of the benefits, aspirin, calcium, there hasn't been a lot of data to suggest strict bed rest, fish oil, folic acid, garlic, vitamin C, D, and E have a great effect with preeclampsia. Pitting edema, 2 millimeters, so ABCD, 1, 2, 3, 4 pitting edema, 2 millimeters, 4 millimeters, 6 millimeters, 8 millimeters. So this patient here has 4+ pitting edema, not good. Clonus, obviously, is not good either. And then mild gestational hypertension and mild preeclampsia usually can be treated a bit more conservatively. Chronic hypertension, again, those should be treated, and we should watch for preterm birth and growth restriction of the fetus. The drugs that we can use, I use a lot of labetalol. Labetalol is safe in pregnancy, but other beta blockers are safe as well. Nifedipine, IV hydralazine if needed, can be used. Patients should be admitted when needed. Loop diuretics, steroid injections, what you guys do. So, importantly, this is kind of a review. Hypertension during pregnancy is common. Urgent delivery and induction is recommended with other adverse conditions like pulmonary edema, coagulopathies, and fetal distress. And very importantly, there's a twofold increase in early onset cardiovascular disease, atherosclerosis, STEMI, non-STEMI, stroke, etc., later in life in patients that have preeclampsia. And the pathophysiology of preeclampsia and peripartum cardiomyopathy are very similar. So kind of some real-life directions. So I practice in Savannah, Georgia. I do some outreach in Hinesville. And there's a hospital there, Liberty Regional Hospital, who has started a program which has really helped the moms in that community a lot. It's called the Mom's Heart Matters program. And basically with this program, the patient, they get access to care, cardiovascular health, lifestyle and wellness, et cetera. And what happens is it's a digital sort of program where they get text messages, they get reminders. If their blood pressure is high, they're contacted by a nurse who sort of helps to triage these patients, and if they need to be seen by their OBGYN, a cardiologist such as myself that can sort of close the gaps there. A grant was written by, not me, but someone in this room, Keisha Callens, along with Seth Workway and other great doctors there have done a really great job. And we've seen some good results with this. So thank you.
Then it improved. So it got to about 35%. I just saw her a couple weeks ago. And so right now her EF is 35%. So that was just an aside. She's got an Explanon. She didn't have her tubes tied. But she has an Explanon.
Wow.
My question is, nothing to do with that. In someone that has a history of preeclampsia that you listed on just taking a history, what should we do differently in terms of screening them later in life compared to any other woman that we're monitoring?
That's a great question. So patients with preeclampsia, at least how I treat them, what's recommended is they're connected with a cardiologist. So I would look at that patient like a patient that is 45 years old with diabetes, hypertension, hyperlipidemia, who has a family history of coronary disease. They themselves may not have manifested that yet, but they need close follow-up and screening. They'll probably, for an asymptomatic patient, eventually need something like a calcium score just to further risk stratify them. And they'll need to have early access to things like statins, et cetera, to minimize their risk long term. So they just need basically close follow-up.
Doctor, thank you, and thank you for coming to the rescue of many of our patients in Chatham County, and we welcome your input. So can you speak a little bit about the use of Lasix? One thing I've been doing is I've been enlisting the help of the nephrologists, actually, in acute blood pressure management. They seem to be much more receptive in our institution, and some of them are using 20 milligrams of Lasix every 8 hours for 3 doses. Something I came to realize just recently is the vasodilation effect of Lasix. I thought it was mainly unloading volume, but actually, apparently at higher doses, it has an effect on vasodilation.
Yeah, so if the patient has signs of acute volume overload, so the cardiomyopathy patients that have pitting edema, pulmonary edema, I do recommend they use a loop diuretic. That can be done as an inpatient if needed, or as an outpatient. Some of these patients can just be managed as an outpatient. An important thing to remember is the IV Lasix, it's got a 2-to-1 strength compared to oral. So if you have a woman that has a lot of edema that you think you can manage as an outpatient, Lasix is completely fine. It does have some vasodilatory effects once you get to 40, 80 plus milligrams, but I have no problem with Lasix. Lasix is great.
What about universally using it every pre-appointment? Because they go home 3 days. I'm just
Yeah, I think you got to look at the patient. My only issue with that is not every patient becomes volume overloaded after they deliver. A lot of them do. I think what's actually probably more important, and it may be aspirational, I can't even go back, but they just need basically close follow-up and frequent assessment. And then if they need it, they need it, but if you give every patient, you're going to run into some hypotension and dehydration.
I would like to speak to these terms, close follow-up and frequent assessment, because I've sent, optimally there's a system and you can put your patient in the system and then the cardiologist, knows to follow them. But when there isn't, I've had patients come and then they delivered somewhere else and they give me this history of this horrible cardiac, issue. And so when I send them to the cardiologist, what should I use as an ICD-10? I've written these long consultations and I hear, oh, they just saw me and then they just let me go. And no, I don't have a follow-up appointment. Shouldn't there be some kind of standard? Do you cardiologists sort of automatically see patients 3 times every 3 months, or is it just episodic? I mean,
Are we talking specifically about preeclamptic patients?
Yeah, delivered patients who've had cardiomyopathy and severe preeclampsia during their pregnancy.
Yeah, so patients that had cardiomyopathy, I didn't touch on this, but they should be getting an echo every month. And after they deliver, they should be getting an echo every month until you get to like 3, maybe 6 months out. And you should be seeing those patients, and what should happen and what happens in practice, unfortunately, are 2 different things. But what I try to do and what I recommend is you see those patients every month until they've demonstrated stability in both their symptoms and their ejection fraction. And then for the preeclamptic patients, in their blood pressure. And hopefully we can sort of titrate off the labetalol, et cetera, and put them on things like either, another easier to take beta blocker or something like Norvasc, where they can take that and it's a little easier for them to take. But they do need frequent assessment. It's hard to standardize what every physician does. There are a lot of physicians, cardiologists, that don't see pregnant women. That I didn't know that was a thing, but that's a thing. So it's hard.
Is there any ICD-10 code that we should use that would sort of make them understand we really would like this patient to get, follow-up and echoes, and do you all have
I think preeclampsia. The one for that. But yeah, that diagnosis, in my opinion, says it all because of all the risks associated with it, or peripartum cardiomyopathy, or pregnancy-associated myocardial infarction. All those diagnoses have associated ICD-10 codes. Keisha.
Thank you, Dr. Abisogun. That was excellent. But I wanted to share with the audience one disclosure. His mom is an OBGYN, so his sensitivity to these issues is a little bit different. And so I just wanted to point that out.
Thank you.
All right. Thank you. I think now we have one final prize to give away. Is that correct?
We have a few final prizes to give
Okay.
away with our partners at the Department of Public Health. They are, for those of you who visited their booth and spun their wheel, they are giving away free registration to this next year's annual meeting. And the winner of that is Llewellyn Hutchinson.
Yeah.
Are you here today? All right, fantastic. They're also giving away a free registration to our GAP QC meeting. And that winner is Dr. Callens. And our grand prize that y'all waited for is a free stay at the Cloister for next year's meeting. So, very worthwhile prize. And the winner of that is Claude Crosby. You must be present to win. So if he's not here, all right. Steve Gary and Paula Graves. Thank y'all so much. prize winner. Thank you all so much for a great conference.
All right. So thank you, everyone, for a fabulous 72nd Annual Scientific and Educational Meeting. Please note that information on obtaining your CME and the meeting evaluation may be found on the online meeting platform. And I repeat, you will receive your CME certificate by going through the online meeting platform and selecting the green CME button. So we'll see you all again next year at the Cloister in Sea Island. Make sure to book your rooms ahead of time as these go quickly. Thank you.
He's been waiting around for the weekend, figuring which club is sneaking.